So here's the key. What are researchers saying, like Giovanni Fava? Beginning in the 1990s, he's a psychiatrist from Italy. Antidepressant drugs in depression might be beneficial in the short term, but worsen the progression of the disease in the long term by increasing the biochemical vulnerability to depression. They may propel the illness to a more malignant and treatment unresponsive course. And what you see, there's been a lot of studies that are saying that indeed that's what we're seeing. This was a screening for depression that found that those who were diagnosed and treated with antidepressants had a worse outcome than those diagnosed and not treated. Another study found that when Zoloft was added to exercise, that led to a greater persistence of depression than exercise alone. There was a long-term study published in 2017, and what did they say? Symptoms were more sharply elevated 9 years following treatment, including medication, than treatment without medication. This pattern suggests possible long-term iatrogenic effects of antidepressants. For example, antidepressant medications may recruit processes that oppose and eventually overwhelm short-term benefits, resulting in loss of efficacy, resistance to retreatment, paradoxical effects, and withdrawal syndromes. Giovanni Fava says, we may propel the illness to a malignant and treatment unresponsive course. And here's the really sad part of this. When drug treatment ends, these processes may be unopposed and yield withdrawal symptoms and increase vulnerability to relapse. Such processes that make you more vulnerable to depression may not be reversible. And so here's a major mood disorder scholar saying it looks like the drugs can induce something called tardive dysphoria, a late onset in dysphoria. You can read this. So you get treatment-resistant depression, people becoming chronically ill. This is what's in the research literature, but of course, none of this is ever communicated to the public. And I'll just show you what's happened in this disease era. The number of adults receiving a disability payment due to mental illness, you see it's gone up from 1.2 million to nearly 5 million by 2009. I also I was asked by a work group in the UK Parliament to look at the use of antidepressants and government disability mood disorders. You see number of government disability due to mood disorders goes up as more antidepressants are used. This happens in the United Kingdom. This happens in Australia, Denmark, Iceland, Sweden, New Zealand. And here's the other thing. We began medicating kids in 1988. At 1988, there were about 16,000 kids on government disability due to mental illness. By the time of 2011, we had nearly 800,000 kids receiving a disability payment. I know I went real fast on that. But what you see in this review of long-term outcomes, in the research literature, you see study after study that is saying of various types that antipsychotics seem to be worsening long-term outcomes, increasing the risk of relapse, causing people to become more biologically vulnerable to psychosis, impairing functioning, that sort of thing. And we see something similar with antidepressants. It changes in the antidepressant era from an episodic to a chronic disorder. People wonder why this might be, and they point to how the drugs cause biological changes in the brain, the opposite of what it is originally intended by the drug. And they say that once this change happens in the brain, where what happens if you go on an SSRI, which ups serotonergic activity, your brain decreases its own serotonergic activity. And even if you come off, it's not sure that it's always going to renormalize. So you might have this sort of permanent tardive dysphoria set in. Now just look at these calls for change at the top. This is from Danius Purse, UN Special Rapporteur on the Right to Health. There is now unequivocal evidence of the failures of a system that relies too heavily on the biomedical model of mental health services, including the frontline and excessive use of psychotropic medicines, and yet though these models persist. This pattern occurs in countries across the national income spectrum. It represents a failure to integrate evidence and the voices of those most affected into policy, and a failure to respect, protect, and fulfill the right to health. And this is from the World Health Organization in 2021. What do they say? A fundamental shift within the mental health field is required in order to end this current situation. In the mental health services context, this means a move towards more balanced, person-centered, holistic, and recovery-oriented practices that consider people in the context of their whole lives, respecting their will and preferences in treatment, implementing alternatives to coercion, and promoting people's right to participation in community inclusion. So we've gone about 90 minutes, almost 90 minutes, and we'll do a few minutes on what's next. This, in some ways, is a story of a tragedy, of course. It's a story of lives that have been harmed, lives that have been impaired, lives that have been lost. And this has happened while we were told a false story about drugs that fix chemical imbalances in the brain. That's a real betrayal of the public. The other betrayal is, as they got these bad outcomes in the long-term studies, whether it be of depression with antidepressants, antidepressants in kids and suicide, stimulants in kids, antipsychotics, and people diagnosed with schizophrenia over and over and over again. We see in those studies where the people who get off medication, on the whole, have better outcomes than those who stay on the medications. All of which calls for a rethinking of the use of the drugs. And yet that information is never presented to the public because, of course, if it were, it would threaten this whole industry of prescribing psychiatric drugs, and in essence, what American psychiatry does and psychiatry does around the world, which is prescribe these drugs. So the public this information has been kept from the public in order to keep this other narrative, this disease model narrative alive. So what's next? Here's the good news, is that what you see in all these studies is so often psychiatric difficulty can be an episodic problem, a time-limited problem, and that people are responsive to their environments. And so if we change the environment, often we can increase that sort of natural capacity to recover. So what's a new narrative for mental health? It begins with this. Rather than trying to say, we know this or that, we should start with humility. The human mind is a mystery. It is a very complex, sophisticated place. And what we all know is that growing up is difficult. We know that we are subject to strong emotions, jealousy, worry. We can be, sort of up and down emotional changes. So this idea that we're supposed to be emotionally stable creatures, it's just not true. That's not what we see through history, through books of philosophy, what we see in our films, our novels, what we see in Shakespeare plays. Human beings are very sort of emotional. They have emotional outbursts, and they have good times, bad times. This is part of what it means to be human. And most important is, environment matters. We are built to be responsive to our environment. And what you really look when you see psychiatric difficulties, you see there's a lot of pathways, physical illnesses, cardiovascular problems, syphilis leads to it, Parkinson's disease can cause psychiatric problems, environmental toxins can, for example, lead was known to cause a lot of problems. Physical illnesses like pernicious anemia, they can cause all sorts of psychotic symptoms. Poverty can, trauma can, difficulties in the family can, loss can, social isolation. These are all environmental things too. Lack of meaning in life, social inequality, use of illicit drugs, prescribed medications, et cetera, et cetera. In other words, there isn't just some singular cause in the brain with molecules that lead to these problems. There's a lot of different pathways that lead to anxiety, depression, worry, compulsions, psychosis, lack of sleep, etc. So think about this new narrative. We have humility, the mind's a mystery. 2, there's all sorts of pathways to difficulties. And frankly, that difficulties are part of life when we're growing up and continue. And that we humans are responsive to our environment. And if you want to look at the social determinants of health, you're going to want to improve the environments. I just want this one quote. Back in 1975, Harry Solomon Sanborn Bachman said this: The majority of mental illnesses, especially the most severe, are largely self-limiting in nature if the patient is not subjected to a demeaning experience or loss of rights and liberties. They can add here, I think, to are not exposed to chronic use of medications. But this is what we can grab on to be to be hopeful. Most psychiatric problems, including psychosis, are depression, anxiety, behaviors that get labeled as ADHD. They're self-limiting in nature. You can have a time of difficulty unless we do something to turn them into chronic conditions. Now, if we go and search through the research literature and find either previous models of care that sort of eschewed drugs and looked at environment as ways of helping people, and also do that in previous times, in current times, over and over again, you find relatively good outcomes, even with, quote, the most severely ill. In the first moral therapy was done. It was invented by the Quakers in the late 1700s, early 1800s. They began developing small asylums in the countryside. And here was their thought. We don't know what causes psychosis or insanity, they would say. But we do know, they are brethren. And we also know they're creatures of God. And as creatures of God, they have a God-given capacity to recover, often have a God-given capacity. So, and what our job is to provide help facilitate that natural capacity to recover. And so they built the first asylum in York, England. The Quakers in New York opened such asylums in the United States in the 1800s. And the idea was good food, exercise, people dressed normally. They would give them things to do, or they would not only exercise, they would garden, they would go on walks, they would have their own newspapers, they would have dances. And what you see with moral therapy, and then I'll go through these others real quickly, is that for first episode patients, a majority would recover within 12 years. And these are people who are severely ill and would not relapse into illness. And even sometimes chronic patients got better with this form of care. Now, Worcester Asylum in Boston opened in the 1830s as a public hospital. And they looked at discharged patients. A long-term study was done of patients discharged over a 13-year period. And what did they find? Treated with this form of environmental care, 58% remained well throughout their lives, 7% relapsed, but subsequently recovered. In other words, 2/3 they got discharged and were able to live in the community. And that's without any, disability support services. But about 1/3 did become chronically ill or died while still mentally ill. Okay, but 2/3 got better. Basically the same things at Pennsylvania Hospital for a 40-year patient. 45% were discharged as cured, 25 as improved. And now what do we see in the decade before the arrival of antipsychotics in asylum medicine in 1955? You see something very similar. At Warren Hospital in Pennsylvania, 62% admitted for at least 4 years were discharged within 12 months. Delaware State Hospital, 85% were discharged within 5 years. Stay well rates, around 70%. Again, over and over again, if we look at first episode patients who aren't put on, antipsychotics, this was before, would get discharged and be functioning okay 5 years after their initial hospitalization. I just real quickly, when they did do a study in California about discharge rates for first episode patients after the introduction of Thorazine, actually discharge rates were higher for those treated without neuroleptics. And I just did this table of outcomes in different countries where people are diagnosed as insane, schizophrenic, or psychotic, and this is outcomes from the pre-antipsychotic era. York Retreat, 70%, Worcester Asylum, 65%, Pennsylvania, 45 to 70, 73%, 70, 76, 63, 88%.